big welcome to you this morning. Thank you for taking the time to be with us this morning. A reminder of our team. So for those of you who are new online, maybe haven't met us before, this webinar series is really the brainchild of Dr. John Higginbottom, whose picture you see, and all of our wonderful technological people and content experts are on the bottom here, starting with Manny on the left and Jen on the right, and Jordan, who really built the PSR platform for us. So big thanks to them. And you're hearing from Regina today. So our initially we were funded by the Ministry of Health in British Columbia to provide leadership and guidance. We are so grateful to many of you who have spoken, who have taken the time and the energy to share your expertise with us. Please have a look on our website for psyrehab.ca. We have, I think, 55 archived webinars on there. So we love to, when people go back and they have a look at them. And if you're interested at all in offering us a presentation, please do contact us and say, you know, let us know if we can help you do that. Our mission is really to advance the work of evidence-based and evidence-informed practices, and we've also done some consultation work as well with some organizations who may be interested in considering recovery-oriented practice. So that's really what we do. We do want to start today's presentation with an acknowledgement. As Douglas College staff, we wish to acknowledge the Kikwetlem and Kikwat First Nations, as well as all Coast Salish peoples on whose traditional and unceded territory we live, learn, work, and play. And after the webinar, and in fact, probably by early next week, you'll receive an email asking you for some just to fill out an evaluation form. So it would really mean a lot to us if you take a few minutes and just let us know how we can improve, what's working for you. And that's another place to let us know if you would be interested in presenting. Also, we just a reminder of the Mental Health Commission of Canada with great website for wonderful archived webinars. They're doing some really great stuff and great documents. So just a reminder that it is a wonderful resource for people with lived experience, for loved ones, and for people delivering services. And also PSR Canada, if you're interested in really improving your practice and reflecting on perhaps some things that you're doing really well and may want to do some more learning around, we recommend that you download the competencies as a way to just do that reflection. And it brings me today a great pleasure to introduce to you Dr. Shu-Ping Chen, who's all the way from Alberta, so we're grateful that she's on a different time zone and presenting with us. She is assistant professor at the Department of Occupational Therapy in the University of Alberta. Dr. Chen's teaching and research focus on people with mental health issues, including social inclusion for individuals with mental illness and mental health promotion. She's the author of a publication we'll hear about today called Recovery Education Program for Inpatient Health Providers. I'm really excited that we have her today, because I think when we speak about recovery, not often do we really speak about how to promote recovery in like acute care. So, and this document was published last year by the Canadian Association of Occupational Therapists. With expertise in research related to stigma reduction, recovery and substance use and misuse, Dr. Chen's research addresses people's activity limitations to engender hope, develop an identity separate from the illness, reduce stigma, play meaningful roles, and promote self-determination. So with that introduction, we're going to pass it over to Shu-Ping, who will just get us going on this topic this morning. So Shu-Ping, over to you, and she is just going to get herself all organized there. There we go. Nice. Great.
Okay, so can you see me and my slides?
Yep, and we hear you well. Thank you.
Okay, so good morning, everyone. Welcome to the webinar. And thank you, Dr. Casey, for the nice introduction. Today, we are going to discuss recovery, especially tensions embedded in the inpatient context. So I think although we know most attention of recovery-oriented mental health services has been focused on community settings, and inpatient hospitalization can also be designed and implemented to be experienced as recovery promotion. So this is our purpose. We would like to introduce an evidence-informed approach to delivering and strengthening recovery-oriented practice in inpatient settings. So today we will talk about assessment of the inpatient context, an inpatient-specific recovery competency framework, the real-life dilemmas in inpatient settings from a recovery perspective, and apply tension-based practice to manage these dilemmas. Let me see how to move. Okay, yes. So before we start, I want to share this artwork created by a lady who expressed the meaning of recovery by this painting. She said, self-exploration is a never-ending cycle between chaos and order, darkness and light, disappearing down to a rabbit hole and crawling up your way is far from easy, but the payoff of greater peace of mind is like winning the lottery of life. Is it nice? So the other, I think the other quotation by Deegan, I think everyone is familiar with Dr. Deegan. She expressed recovery as stay in the driver's seat of my life. And she said, I don't let my illness run me. Over the years, I have worked hard to become an expert in my own self-care. Being in recovery means I don't just take medications. Rather, I use medications as part of my recovery process. Over the years, I have learned different ways of helping myself. Sometimes I use medication, therapy, self-help, and the mutual support groups, friends, my relationship with God, work, exercise, spending time in nature. All these measures help me remain whole and healthy, even though I have a disability. Okay, I think these two quotes provide a foundation for our topic today. Today I will cover 3 parts. First, I will give you a brief review of the recovery concepts and the strategies to promote recovery. Then we move on to think about the inpatient context. I will talk about evaluation and the preparation of the inpatient environment for delivery of recovery-oriented services. And finally, the third part will be today's main focus, tension-based practice in the inpatient context. Okay, so first, the recovery concepts and the strategies to promote recovery. Here are 5 key concepts of recovery. First, recovery is a nonlinear process. People move forward and move backward. Setbacks can be part of the long-term recovery process. Relapses are not failure. So when people readmit to the inpatient unit, that's fine, right? We see this as a learning process, as a part of a person's recovery journey. Second, recovery is an ongoing journey, not a destination. People keep learning, finding new meaning in their lives. We discover a new self every day. Life involves endless learning. We don't say, okay, I recovered, this is the end. Third, recovery means different things to different people. Everybody's recovery journey is unique. So for example, you can hear people say, to me, recovery means having a reason to get out of bed. Maybe getting involved in things I enjoyed, or having people I can count on. So recovery means different things to different people. Fourth, there is no right or wrong way to recover. Everybody has the expertise of knowing themselves. Everybody has a unique way to manage their health and well-being. Final one, personal responsibility. We know recovery is people's own responsibility. You cannot do recovery to someone. Okay. So based on a comprehensive literature review, we developed this diagram presenting 3 major factors related to recovery. The first category is biological factors. The level or severity of psychiatric symptoms and the side effects of medication does influence people's recovery. For example, people who have mild symptoms or has less side effect of medication experience less challenges for recovery. Personal factors, including hope, acceptance of mental illness, feel empowered, have a sense of control, taking personal responsibility to their recovery, is goal-oriented and eager to succeed, have a good coping skills. These factors all lead to positive recovery outcomes. Finally, the environmental factors. Let's think about the influence of people's environment. Factors can include their quality of life, the level of productivity. Do people work part-time or full-time? Do they volunteer or do they play a productive life, productive role? Does the environment provide opportunities for meaningful engagement? How about people's support network and the connection? Is the service providing system accessible and friendly? We all know stigma and discrimination does influence people's social participation, and stressful life events such as loss of loved one can have negative impact on people's recovery. So all these 3 categories of factors are related to people's recovery. So how to enable people's recovery process? Although an individual is responsible for his or her own recovery, as a service providers or family members, we can function as a recovery guide to enable people's meaningful participation in achieving recovery goals. So we can say people recover, but we can enable. Our role is to facilitate the individual's process toward recovery. So here I proposed 7 strategies to promote recovery. Number 1 is hope instillation. We help people develop a positive outlook in a given situation. We encourage small successes and emphasize possibilities rather than limitation. So it must be concrete. We set goals. We create workable strategies to achieve those goals. Have a positive belief about the ability to plan, initiate, and sustain goal-oriented behaviors. So for example, there is a 4-step hope instillation practice. Step 1, hope finding. We work with people to identify factors that have contributed to hopeful thinking and invite them to tell stories of hope. Hope bonding. We identify tasks, goals, and the bonds essential in forming a hopeful therapeutic alliance. We can model hopeful thoughts and behaviors. We can provide empathy, trust, and understanding. Then hope enhancing. We can identify people's strengths and assist in developing skills to achieve the hope. Finally, hope reminding. We help people revisit times when hope was a positive factor in their lives. Okay. Number 2, developing interpersonal expertise. We all know that listening and the proper self-disclosure is very important. Examples of positive disclosure include modeling hope, modeling positive thoughts. However, we need to avoid negative disclosure. For example, shifting the focus of attention to your own need rather than people's need. Number 3, empowerment. You can see this picture. Empowerment is a continuum from disempowerment to empowerment. There are 6 strategies that foster empowerment. Increase personal capacity. We can help people increase knowledge and skills. We can provide opportunities for participation, provide choices, help them remove barriers, access to resources, and provide support. So you can see people will feel more powerful if they have skills and knowledge involved in activities, can make their own choices, have less barriers, and have resources and support. Number 4, responsibilities. We can take steps to encourage people to take responsibilities for their own recovery. For example, we can ask them, what are 3 things you did for yourself during the previous weeks? Or what are 3 things you can do for yourself during this coming week? And what are your own feelings and the reactions to this exercise? So I think these 3 are very good questions for people to reflect on what they take for themselves. We can say, in the past, you may have waited for experts to fix your problem. Now you know that. While others can play an important role in your recovery journey, you need to step up and play the main role. You need to be in the driver's seat, right? Number 5, therapeutic risk-taking. We need to shift our thoughts from risk control to risk management. Here is the thought. If risk is defined as the likelihood of something happening that could have potentially harmful or beneficial outcomes, we think therapeutic risk-taking is about having the opportunity to make the choice to follow that course of action. We can think creatively and work collaboratively with the people to plan for people's action. However, we need to be in the context of a therapeutic relationship that provides a vehicle to support people to take risk and make discoveries as part of a nature-like process. We expect risk and have a plan to mitigate the risk. That's risk management. Number 6, strengths-based practice. We amplify the well aspect of the individual and mobilizing the individual's strengths. We can help people see and use their own strengths, get strengths in their useful form in order to achieve goals, remove barriers, and help people find the perfect niche. So the major idea here is using people's strength to plan goals. Number 7, peer support. The peer support worker provides emotional and social support to others who share a common experiences. So the commonality may not be in relation to a specific challenge or illness, but rather to the struggle and the emotional pain that can accompany the feeling of loss and hopelessness during the mental illness. To summarize, so now we have discussed 7 strategies to promote recovery. They are hope inspiration, developing interpersonal expertise, empowerment, responsibilities, therapeutic risk-taking, strengths-based practice, and peer support. Now we move on to the inpatient context. Before we advocate for recovery-oriented practice in inpatient settings, we need to evaluate the environment to see if it's recovery-oriented. Okay, so here is a tool we can use to evaluate the environment. It's called the Recovery Self-Assessment Administration or Manager version. It contains 35 items that assess 6 domains of recovery. Here you could see part of the tool. All items consist of a brief statement with a 5-category Likert scales from 1 strongly disagree to 5 strongly agree, and the options of non-applicable or DK, don't know. So this tool is a useful self-reflective tool for identifying strengths and the areas for improvement for a setting. So this is the scoring sheet for RSAR. It contains 6 domains. Life goal. So we think, do staff help with the development and the pursuit of individually defined life goal? Involvement. Think about, are people involved in programs, services, staff training, and the management meetings? Diversities of treatment options. Do we provide links to peer support, a variety of treatment options, or non-mental health activities? Choice. Do people have access to their treatment records? Do staff respect and avoid influencing people's choices? Individually tailored services. Are services tailored to individuals' needs, culture, interest? Inviting factors. How about the human and the physical environments? Is it welcoming and comfortable? So you can add the total scores for each domain and see the level of recovery orientation at your setting using this scoring sheet. Then, after completing the evaluation of the environment, you have a better idea about your current context in relation to recovery-oriented practice. Based on the assessment results, this is the flow chart that will guide you through each step of program implementation. We first think about the hospital or the inpatient units. Are they committed to promoting recovery-oriented services? How about the unit manager? If the answer is no, we could develop some strategies to increase their buy-in. For example, see the blue box. We could provide information about recovery. For instance, important policy documents that support recovery and evidence-based recovery practices. We can also host a meeting with the manager, bring managers on site, develop potential alliance, visit model recovery-oriented programs, and request input and feedback from current and former patients. If the answer is yes, we can move on to see staff's attitude and the motivation for change. Prepare to open conversations with the team and the staff, reflect on their current practice, etc. Okay, so now we enter our key section today, tension-based practice in the inpatient context. A bit background. Okay, so although psychiatric hospital has been downsized or closed, we think inpatient settings still serve a significant function in the mental health system and can be a critical part of an individual's recovery process. So through a systematic qualitative study, a tension practice consequences model was developed. So this model identifies several points of tensions in delivering recovery-oriented services in inpatient context. In this model, tension refers to a situation where service providers are faced with a situation where they are constrained in their ability to provide recovery-oriented practice. So this is the model. So this model is based on a qualitative research. The tension practice consequences model presents tensions. We can see 3 levels of tensions. Environmental level. In the inpatient setting, we can see there is a poor physical environment, inflexible routines, limited resources, and so on. For the personal level, people have psychiatric symptoms, behavior issues, cognitive issues, lack of motivation. Providers level, provider do not have support from other team members, do not have knowledge and the skills, don't want to change, don't believe in recovery. So these three levels of tensions can lead to current practice that adopt medical model, custodial framework, and risk control. As a result, patients have limited engagement in the inpatient unit, feel segregated, restricted, have constrained communication, and passive. Finally, hopeless, powerless, and compromised relationship with providers would be the consequences. Okay, so the recovery enabling framework was developed to help providers promote recovery in inpatient setting. There are 4 processes we can do to promote recovery and reconcile those tensions. So process 1, engage with patients to reduce the 3 levels of tensions. And process 2, we provide individually tailored services that including engage patients in setting goals and planning, and provide choices and individualized services. Process 3, we foster a positive cycle of recovery. And finally, process 4, transition. Because this is an inpatient setting, we need to ensure the continuity of recovery process after discharge. Okay, so based on this framework, today I would like to discuss 10 major tensions and how to reconcile these tensions with you. Okay, so tension 1, lack of agreement between patients' needs, choices, and the structure of the unit. For example, it is difficult to address different patients' needs in a restrictive environment. If you see that left-hand side, the yellow box, we think what rules and routines can be perceived by patients as rigid with respect to what activities are permitted and restricted with regards to the time and the space for these activities. Okay. However, providers have to maintain the order of the inpatient settings and ensure patients' safety. Right. So think about what can we do under such tensions. We can demonstrate an understanding of patients' experiences. We help patients articulate their needs, negotiate the dilemmas between patients' choice and the work structure, and provide a wide range of options and promote positive risk-taking. So, for example, just very simple small things. We can open a certain space or a certain time for patients to do something they would like to do. Just be flexible. When I interview patients in the inpatient settings, they all complain, I would like to take a shower after a gym activities, but we can, because of the time restraint, we can only take a shower every Tuesdays, Fridays, and Saturday mornings. So I cannot do whatever I want to do in a certain timing. So this is a restriction. Okay. Tension 2, challenges related to ensuring human rights and delivering sound interventions. Okay. For example, those interventions for maintaining a safe environment, we need to search through people's belongings for dangerous objects. Some kinds of controls are seen as part of treatment. For example, the use of behavior contracts to prevent destructive behaviors. It seems like these are necessary in the inpatient unit. However, we can create a supportive and accepting atmosphere, and use understandable, respectful, and empowering verbal and body language. When you do the search, attitude and the body language does matter, right? How can we create a respectful environment? We need to convey attitude of active respect and dignity for patients' rights. As the providers, we must be willing to share information, knowledge, responsibility, and power with patients and their significant others. Tension 3, challenges in delivering services that are strength-based in a context that is largely problem-based. As we know, the inpatient context adopt problem-based approach. We do evaluation, we identify problems, fix the problems. The philosophy is nothing can be done until symptoms and the problems has been solved. On the other hand, strength-based approach emphasizes the use of people's strength to overcome their symptoms. Okay, so to solve this tension, we need to demonstrate a holistic understanding of patients by assessing people and their context objectively and interpret their deficits within a strength and resilience framework. Think about how to use their strength, even they are in acute distress, and then set individual recovery outcome indicators that specific to the individual and help them plan concrete next step. Okay, so think about how to use people's strengths to achieve their goal. Tension 4, the inpatient context places time restriction on services that compromise the delivery of recovery-oriented services. So the first challenge is the high turnovers of patients. Providers do not have enough time to implement recovery planning. Most of the inpatient admission, I think patient discharge within 7 days or 2 weeks. Right? The second challenge is providers' time constraints. Providers do not have enough time to offer time-consuming services or cannot satisfy different patients' needs at the same time. Okay, so in this case, we need to prioritize patients' goals and the needs. Think about what's the most important priorities for patients and develop and lead groups which are organized to meet individualized goals for each patient. So we can use a group setting to address people's needs at the same time. Tension 5, challenges related to sharing power with patients. So let's note up that providers hold the power in the system. Okay, the decision making and the communication tend to be top down. So for example, providers or doctors have the power to make the decision to discharge a patient, right? Okay, so here's the thought. Service users are vulnerable to power. They are vulnerable to feel attacked and hurt by providers because of the power imbalance that is expressed through providers' language and behavior. On the other hand, providers can feel uncomfortable when sharing power with inpatients because they worry that professional boundaries and authorities may be undermined. Providers may not have confidence in inpatients' judgment, right? So we need to renegotiate the power structures. As a providers, we have to recognize and take an honest look at the hierarchy of power structure. We need to self-reflect and change assumptions. Think about, am I the expert and do I know best? We can share our traditional power of making treatment decisions and the control over the services, and encourage people's participation in deciding their treatment plan. Okay. Tension 6. Inpatient experiences of acute illness or distress prevents them from engaging in activities associated with recovery. So the level of acuity of mental illness can affect functional capacity and challenge the ability to promote recovery. In this situation, greater attention is paid to safety issues in responses to the mental instability of the patient served. Okay. So think about, we need to understand patients and their stages of recovery, apply motivational enhancement strategy, and integrate biopsychosocial models of intervention through implementing evidence-based practice such as psychopharmacology, cognitive behavioral therapy, and psychoeducation. So think about this. Even patients are in serious distress, we can still do something. For example, when people are just starting to think about recovery, or the possibility of recovery may seem neither possible nor desirable, they don't think they can recover. We can have them hearing and reading other people's story of recovery. We can introduce them to other people in recovery who have been in similar situations, like peer support worker. We can create space for people to talk about recovery and think about what it means for them. So, Tension 7. Challenges related to lack of colleague support or sister support for delivering recovery-oriented services in the inpatient setting. So as we know, the level of recovery competencies of providers varies. Sometimes the team culture perceives patients as incapable, and the providers have a tendency to act as a problem solver, dominating the decision-making process. So under this tension, a provider must be able to reflect on their practice, advocate recovery within the inpatient team, and be able to resolve conflicts or issues raised in recovery-oriented services, and facilitate interdisciplinary communication. Let's say, as a provider, we need to be able to speak up for our clients, for the individual. Tension 8, dilemmas that exist when it is believed that patients' decisions may lead to harmful or negative outcome. We used to assume that the acute conditions compromise patients' judgment, and this can lead to unintentionally discriminate and limit opportunities and autonomy for inpatients. There is a high expectation that providers can manage all possible risks to ensure patient safety. As a result, providers tend toward being risk averse. We don't trust patients' decision. Okay. So to reconcile these tensions, we need to encourage patients to make choices and help them through the decision-making process. We promote safety and positive risk-taking. We support patients in turn setbacks after they choose to take risk. It's okay, you choose to take risk, but we support you if something goes wrong, right? It's still okay, we can learn from these experiences. Tension 9, dilemmas that exist when patients are in a negative cycle of hopelessness and repeat relapse. So loss of hope can lead to giving up or withdrawal and may inhibit patients' outlook regarding possibilities for present and the future. Some patients may be in a negative cycle of hopelessness, powerlessness, vulnerable, and repeat relapses. Some patients may be extremely fragile and have extremely low self-esteem after repeated hospitalization, disturbance in their community connections, or a long-term experiences of illness. So we call this is a negative cycle of recovery. So this a state of hopelessness, the negative cycle can cause by repeat failures. So we need to promote a positive recovery cycle that include hope, empowerment, skills building, readiness to move forward, building network, and advocate for themselves. We can help them to start this positive recovery cycle starting at any point. Okay, I look at my time. Okay, tension 10, dilemmas that exist when stigmas prevent patients from moving forward. We all know stigma, right? People have internalized stigma that is a patient's own belief of negative attitudes about themselves. External stigma is a society's negative attitude based on misunderstanding of serious mental illness. Okay, so in this case, we need to help patients self-advocate and know their rights. Okay, we need to involve peer-provided services in inpatient settings to help our clients understand. Yes, there's a possibility to help them reflect on their internalized stigma. Okay, we need to facilitate the patient's access to self-help group, take a proactive role in reducing stigma. So for example, we can participate in public education, right? We can provide more positive message about recovery to the public. Okay, so to summarize, okay, tension-based practice is the use of tensions in practice to promote the integration of treatment and rehabilitation in a recovery-oriented systems. So tension-based practice includes confront. We need to confront and identify those tensions shown in day-to-day practice. And we evaluate to gain an understanding of the dynamic. Finally, we propose potential solutions to reconcile those tensions and promote the true integration of recovery-oriented services. So today, I try to post some tensions we observed in inpatient settings and then discuss some strategies to reconcile those tensions. Okay, so this is my presentation. I will invite any questions regarding the presentation today.
Thank you, Shu-Ping. That was amazing. I think what you've done in the last 40 minutes or so is to take a very complex system and help us begin to think in a very concrete way how we can begin to tease apart and begin to evaluate the interventions or the proposed interventions to ameliorate some of the difficulties. So I celebrate your language and I celebrate your attention and your informed sense of what some of the complexities are. You call them tensions, but I think it's very much informed by people with lived experience and your efforts at understanding from that lived experience perspective how to improve things within acute and complex care settings. So congratulations and thank you. And I know that was a huge publication in 2018 and a huge accomplishment, Shu-Ping. So, and I don't know anybody else who's tackled those issues in that way. So a warm congratulations to you, Shu-Ping.
Thanks.
I don't know if there are any questions or comments people might have, so we just encourage you to find the chat button that you will find at the very bottom of your screen, and just if you click on that, and hopefully maybe you have comments or questions or thoughts. And I know that systems thinking for some people is very exciting. Thanks for that, Shu-Ping. And for others of us, sometimes it makes your brain hurt a little bit. But I guess that we're all really trying to improve recovery opportunities for people and their loved one who have lived experience of mental illnesses. Yeah, so just really being able to think from that systems perspective, I think, is really really important. Maybe I can begin the chat. I really appreciated the 4 potential interventions around hope. I really like that. And so, but maybe before we go chat with that, Susan asks Shu-Ping, can you give a specific example of a strength-based solution? That was something I highlighted as well, Susan. So thanks for bringing that forward. Thank you.
Okay. So stress-based solution first. Because in the system, we used to think about the problems or the key issues of the kinds, but if we can shift our thought from a problem to strengths, think about what strengths this person have, and then how can we use these strengths in this person's recovery journey. So for example, this person is good at taking care of animals. This person loves dogs. We have a dog conference today, so this is my examples. Okay, so how can we use this as a niche or a helpful resources in this person's recovery? Maybe we can have this person take care of dog and volunteer in the dog society or something like this. So think about how to use strength in people's recovery journey. Is that clear?
Mm-hmm. Thank you, Shu-Ping. Yeah, I think you're just really trying to be, from a very practical perspective, look at and help that individual become aware, or maybe identify some strengths that they have or some interests they have, and creatively finding a way for them to be able to express those strengths in a way that maybe shows the strengths of the person, but also is used to help them perhaps accomplish additional goals. Thank you, Shu-Ping. So Carly says, this may be beyond the scope of the work of the webinar, but can you recommend or discuss in ways to engage psychiatrists in shifting their practice to be more recovery oriented? I find this is a major barrier in inpatient setting, since much of the care is driven by psychiatrists who work from a problem-based medicalized model. So that is a big question from Carly. Thank you.
Okay. I do agree with this comment. When I did my research, the qualitative research I just mentioned, I interviewed some psychiatrists. Okay, some of them told me they think recovery is anti-psychiatrist. Okay, I just don't know how to answer. Okay, so I think to answer your questions, I would say, as a team member in the inpatient teams, we can try to advocate for recovery and telling the psychiatrist it's not anti-psychiatrist. Recovery doesn't equal to not using medication. You know, some psychiatrists think that recovery is okay. People that have a choice, they don't want to take meds. Okay, so we just correct some concept with psychiatrists, have them understand that we can some basic recovery principles, and we can use people's strengths to look at their recovery journey. So it can be we can do recovery at the same time, whatever people still continue their regular intervention if they think it's more important. So just to switch the attitude, the knowledge of psychiatrist. I think the attitude does matter. We can have a more open conversation about attitude concept of recovery. Yeah, I don't know if this answers your questions, but yeah, this is really an issue in the real world.
And I guess Shu-Ping too, part of our job as change agents, which I think is a competency of many professional practices, including psychosocial rehabilitation, is to be a leader and to identify potential allies who might have different opinions, because I think we work well when we are able to shift those opinions and to maybe just try and find some kind of common opportunity to reduce that tension in your language. Because I think when we are able to make that change and we are able to maybe show people some role models, be it whatever profession it might be, we are advancing the work, I think. So I think last week, or 2 weeks ago, I was at a conference in Victoria, and a psychiatrist presented with a person he delivers service to. It was a very powerful presentation, and I think probably changed many people's opinions or ideas in that room, some of whom might be psychiatrists, some of whom might be OTs. And I guess we can all hold, like, irrespective of the profession, we can all hold those ideas. And I guess I'm just advocating to help us to help us be that change agent, right? Because it's easy to be grumpy about it, but I guess we just need to somehow find a way. I'm going to be quiet now to change that.
Yeah, the other thoughts, I think it's very useful to present some recovery related case or studies in psychiatrist related conferences. I think this it's a very good discussion during that setting that we can influence their thoughts.
So this person says, thank you for an extremely informative presentation. So nice for you to get that feedback. And asks as well, I think is just confirming some of these ideas, that it seems that some clinicians are more open to recovery than others. So hopefully we walk away with this idea that just to challenge ourselves as well, to try and bring those individuals to be on and to come into the fold. I remember personally working with one person from a particular profession who was very much against recovery-oriented practice and became a strong ally. And it's not that I'm a brilliant person, but I think just finding that message or finding that way to be able to work with that individual to help, and we all have ideas, right? But to help shift and help people become more open. And then this person says, thank you, Shu-Ping. It's Carly. I agree with the advocacy is really important. We have seen with the recovery movement, this work can be grassroots and can come from direct service and from service users. Well done, she says. Attitude seems a key as we are identify the challenges and turn them into opportunities to better support recovery. And I love that, Susan, because I think as well, when we talk about people having a setback, we really try and frame that as an opportunity. And I guess in recovery-oriented care, we are looking for those opportunities as well. So,
yeah, and I want to emphasize attitude is the most important key point. Yeah, if the provider just show a positive language, a positive body language, verbal language, it changes a lot. And the people can just perceive supportive. Yeah.
Super. Thank you.
Yeah.
Thank you.
Oh, can I say one more? Okay.
Of course.
So, yeah. Some people think, especially some providers think, recovery-oriented practice is time-consuming. It's a specific approach. We need to do more job in order to provide recovery-oriented practice. But I think recovery is a philosophy. It's an attitude. Okay. Yeah. You don't need to do anything specific. It's not a time-consuming approach. Yeah. So I just want to highlight
just a way of being sometimes. Right.
Yeah.
Thank you. Thank you, Shu-Ping. This person says, I'm curious of the recovery assessment, self-assessment and manager version, wondering if it's freely available and whether you found that this was a good tool to help administrators who may not understand recovery orientation to understand this topic, to help with the decision making. I often feel I am speaking a different language from my managers or administrators and look for tools to help us. So I guess two things: is it useful and is it freely available? Shu-Ping.
Okay, so the recovery self-assessment tool, this tool is freely available. You can Google website and you can see the whole version. And we do have this this tool in the book, in the recovery educational package, and we get the permission from the author to post the whole version of this tool. So if you can find on Google search, you can see in the book. And in terms of the usefulness, I think if the administrators do not have concept of recovery, I think we can use this tool to evaluate our setting first, and then use the result to communicate with the administrator about recovery, not for them to use the tool directly. This is my thought.
Mm-hmm. I see what you mean, so that you might do some sort of a scan and then use it to accumulate that knowledge and then bring those outcomes forward to help that person to show in a way how useful it can be, I guess, right? And
yes. So use the outcome as a communication tool to communicate the recovery with this person. Yeah.
I think that's a clever strategy, because you're showing some outcomes, and then hopefully they'll want to see a little more of the tool to get more information for their own system. Yeah, that's clever. I like that. Yeah, thank you. So I just noticed we're happy to have more comments. I know that it's almost lunchtime. It's so neat to have this presentation, I think, at this systems level, because I think when we talk about a recovery oriented, we talk often about personal recovery, which is so essential. But I like this systems approach as well. And I love that people delivering services directly are familiar and exposed to this kind of thinking, because I think, as you say, it's in that way that we can begin to shape and begin to help managers and leaders and policymakers to make the shift as well. So yeah, it's very helpful. Just while we're having this breaking conversation, to let you know that in 2 weeks, we're going to have a gentleman, Jeff, who is a private counselor here in New Westminster, who will speak very much about personal recovery and the skills to just engage with people. So stay tuned for that. So maybe just check out the website and sign up. Very experienced person who's worked in both clinical practice and private practice here in the city. So just a little plug for that presentation as well. Oh, I think we lost cameras there. There we go. Not sure why. That's okay. So perhaps just seeing that maybe there aren't any other comments, just I'll leave that open for another little moment. Sadly, I can't turn on my camera. We have a little glitch with our system this morning for some reason. I don't know, but we're having trouble just turning on my camera for some reason. Anywho, Maybe I can now. Oh, there we go. There it is now. For some reason, it wouldn't work earlier. Anyhow, so just checking in, see if anybody else has any other comments. If not, we will call it a day. That's no problem. I'll just monitor the chat there for a moment. Super. Yeah, and Shu-Ping, I don't know, but the a thing that I really appreciated too is just how specific you were with the hope. And I guess just hearing, sometimes you hear information and then you hear it in a different way and it kind of makes it light up for you in a way. But I love the ideas of hope finding, of hope bonding, of hope enhancing, and hope reminding. And I think that that's a very useful little tool, because I think hope is so big and so powerful. But I think sometimes it is such a large thing that it's very helpful to have a specific way to think about it that helps us think about strategies to support people as we work with them. So cool.
Yeah.
We have a few comments here. Susan says, thank you, Shu-Ping, for all your answers. And Maggie says, what an inspiring presentation. Great to see how we can tackle the environment in which we work. Thank you, Shu-Ping. Very powerful, innovative presentation. So that came from Carmen. So it sounds like we might be at the end of this particular presentation. We say a big thank you, Shu-Ping. We know that you're super busy and you had a big day and a full day yesterday, so I'm sure you're exhausted. Absolutely terrific, as Susan says. So thank you for your energy and your heart to make this happen today. Thank you. And thanks to everybody on the line. We really appreciate you being here with us. Thank you kindly. So we'll sign off and we'll say goodbye and hope to see you in 2 weeks from now. Thank you, Barbara.
Thank you, everybody.